We are now going live on YouTube. So as soon as you guys see that pop up on the screen, we will be live. Please hold tight as the tech prepares.
Good morning, everyone. It is 8:02 a.m. on February 27th, 2024. I'm going to call the Board Health meeting to order. Present, we have board members Frank Ehrlich, Terry Quell, Joan McNeil, Janet Karpiak, Norman Weinberger, and Ken Lalim. Staff members, we have Aniela Pignon, Bill Mooney, I'm looking at my whole screen, Megan Fogno, Darlene Hoffler, Teresa Ardendesi, and Brian Weeks. Thank you all for joining us this morning. The first item on the agenda is approval of the January 23rd, 2024 meeting minutes. Do I have a motion?
So moved.
Norman moves. Do I have a second?
I'll second.
Okay.
I just have one comment.
Okay.
My name is misspelled.
Oh, I'm sorry about that. Didn't catch that. We will make that correction.
No problem.
Are there any other corrections to the minutes? All right. All those in favor with that one correction?
Aye.
Aye.
Aye. Aye.
Any opposed or abstentions? All right. Minutes passed. Thank you. The second item on the agenda is the environmental health file system policy. So we've been looking at all of our policies and staff have been working on updating them, and this is our latest one. And so Aniela is going to give some overview of it, and Bill will also provide some context. Thank you, Terry, for sending us some of your suggestions and feedback. So I'll have Aniela and Bill talk first, and then we'll pass it to Terry to share her feedback.
Good morning, everybody. So the work that Bill and I did on the environmental health policy system or environmental health filing policy system was really to give everybody a sense of how our inspectors and the rest of the environmental health division use the hard copy file system and how they keep each other informed of who has the file system on hand. So the background on this is that there was some confusion between inspectors. Sometimes health inspectors, sanitarians, or housing inspectors would go to find or go to look for a file in the file room, and it would not be able to find it, in large part because another inspector had it at their desk. But it was impossible for them to know where exactly it was, who had it. So a system was developed using a QI process called Lean 5S. And basically what we were looking to do is to refine the process to make it as simple as possible and as standardized as possible. And so the system was developed so that whenever an inspector goes into the environmental health file room, they will actually put a card into the files system where they've taken the file from. And then when they go to their desk, if they're not actively using it at their desk, they will place the file into a hanging file folder system at their desk so that it's very accessible for any other inspector who's looking for it. So this way, it's just very clear to the entire team where the files are, and so there's never a sort of a gap in information or any missing information. So that is the background behind this. And so the system is really a product of this QI process where we took a look at what the issues were. We refined a process to address those issues. And we came up with this process and this procedure to make sure that there was a standardized way for inspectors to find their file system or to find their files within the system. In terms of actually, using the system, there isn't too much that varies from what I just kind of described. The protocol or the process is very simple. It's exactly kind of what I mentioned. There's also the component of the policy that refers to the software that we are using right now. So sometimes, depending on what the file is being reviewed for, we have photos taken and files uploaded into what we currently use. It's called Fox Pro. We will be transitioning to a different environmental health software system in the future. But we did include that information so that it was very clear if there was new if there were new photos or if there was new documentation that needed to be included both in the physical file system and in the electronic environmental health software system, that there was a process for that. So I'm going to turn it over to Bill to see if there's anything else that I was missing or if you wanted to clarify anything.
No, that encompasses mostly what we do. We have a couple of things broken out. So there's a housing file. So all the housing issues are in one group of files. Septic is separated, as is the food. Also, the pools, salons, and daycares are all separated differently. So that's very easy to get to one thing and be able to pull something out. In addition, about a year and a half ago, I sent a request up to the state library, and we went through all the files and everything that we could remove. Violations, let's see what else, complaint, inspection reports, and some notice of violations that are beyond 5 years. We went through everything and took out those and had them shredded. So we kind of took a lot of stuff out, and the file system was pretty crowded, as kind of mentioned in the narrative. And so because we did that, we were able to thin it out quite a bit. So that helped as well. It seems to be working pretty well. Everyone is used to the system. They know where to get their files to, put their tab in if they remove a file from someplace. And when somebody comes in, it happened yesterday, somebody came in looking for something, we couldn't find it right away. I mean, we looked, so okay, it's in Sean's file. We went to Sean's, we were able to pull it up. So it works quite well, actually. So I'm pleased with it. We just need to work on getting the files cleaned up a little bit more, but we're working on that steadily.
Hey, Bill, it's David. Did you guys mention going electronic in the future? Because most places are scanning documents in, making them available. Oh,
Yes, that is one of the things that'll be coming up. The city is looking to have a permitting process for the city. So we'll be incorporated into that in one form or another. So that's going to happen sometime in the near future, yes.
It probably is just me, but looking through the policy, I couldn't find any reference to how long files need to be kept. Are they kept in perpetuity, or do you get rid of them at a certain legal time? And I didn't find any reference to that in the policy.
And that's something we could put in. That makes sense. So there's no requirement to have to get rid of them after a certain amount of time. If you decide to get rid of them, you have to shred them. Certain ones have to be kept for 5 years. Certain things like well locations and septic requirements have to stay in for good. So they're not removed. That's always in there. It's usually the notice of violations, complaints, and those things are beyond 5 years can be removed. But again, there's no set time of when you have to do that.
That's a great suggestion, though. We can work on incorporating that into it.
Yeah, that'd be a good idea. Every so many years we could do that. Absolutely.
Yeah.
and maybe there could be a policy of looking at, there's violations, they don't quite make their score in the restaurant inspection. And then there's people that are grossly out of compliance and have been difficult to work with. I would think you would want to at least keep ones that were more problematic longer to make sure they don't repeat the issue. Because we've seen that in New Canaan,
Yeah, I mean, we could do that, but it's also kept electronically too. So that'll still be recorded in that format.
Oh, well, okay, that's fine. I'm just saying, we just want to know those kinds of things.
Yeah, no, that's a good point.
Terry, can you share some of your feedback?
Sure. I think it's an awesome QI project. You guys did a really good job. My question for the policy, well, I had one question. In terms of closing out files, it says they'll check for floor plans and equipment and scan and upload if possible. So I wasn't sure what you were talking about with equipment. So floor plans, I get that. But what equipment information are you scanning?
Well, the reason we want to keep that, or we try and keep that, is often a place will close out and then someone will take it over either right away or sometime, down the road. And often as part of the zoning and the building process, they need to provide a floor plan. So we like to maintain that so that if someone comes in, they don't have to duplicate it unless they're going to change something entirely. That's different. Then we can provide that to them and they can utilize that for their purposes. So that's why we do that.
Got it. Okay, great. In terms of the policy, I think the policy is great. I think you've done a great job. The question that I had was in terms of having the policy, there is a lot of information in here that's the background, which is great, but it won't be needed to stay in the policy after it's implemented. So I was just thinking you may want to, and I noted that in my comments that I sent. So that's a possibility. That's something that I wanted to touch base on. The other thing was in terms of the lean tool that you used, which was a great choice. Are you incorporating the lean tool into this to look at all the pieces that you've done already in terms of cleaning up the environment in that room? Or are you just using this policy for the files?
It's for the entire room, I would say. The room, including the files, everything that's in there would be included in that.
Okay, so then I would maybe just tweak that a little bit to make it clear that you described what you did already. So I think that could be pulled out and given to whoever as a separate little report, and then just write in there what would be done and how often it would be done, emptying out and removing. We already talked about removing the older files. So just to make that more clear to a new person, not what you already did, but what they should be doing going forward.
Sure.
Yeah, I think it looks good. I like the orange placeholders.
They're bright. You can't miss them.
Uh-huh.
Thanks, Terry. Is there any other feedback, comments? All right, so we'll go back and make some additional edits based on the feedback that we've gotten today, and then we'll bring it back at a future meeting for a vote. Does that sound good?
Yep, great.
All right, thank you all. All right, the next item on the agenda is CAP community outreach. So Megan has done a great job putting together a presentation for you all today to talk about some of the great work that the CAP team has been doing. So Megan, take it away.
Give me a minute to pull my screen up. You guys can see it okay?
Yes.
Yes.
Yep.
Okay. I'm going to be looking down a little bit just because my notes are below me, not on my screen. But so today I'm going to be talking about our CAP program, which is also known as the COVID Immunization Action Plan program. And so this was a grant that we've received similar to the traditional IAP program. And this started back in December of 2021, around then. I know I've presented about this program in the past, but just a quick overview of the program. So our program goals are to increase COVID immunization access and coverage through outreach, education, engagement with the community members, providers, and other key stakeholders with a strong focus on vaccine health equity. Our coverage area includes the surrounding towns. So like traditional IAP, we oversee Brookfield, Danbury, New Canaan, Newtown, Norwalk, Richfield, Weston, Westport, and Wilton. And again, the grant, we started, or we had community health workers on board in January of 2022. So that's really when we hit the ground running with a lot of the work. In December, I held a meeting with Pam, but that's when we really started a lot of the work. And then this grant does end at the end of June. So just a little bit about what we've done to date. So community outreach. So in total, the total events that we've attended have been 372 events, and those were majority in the Norwalk region, but in Danbury, as well as a lot of the surrounding towns, and there was events that we could attend. To the right is a picture of our 3 CHWs. They did end their time with us this past June, and we did bring on a new CHW as of this year in January, Omar Perez Rivera. Some examples of places that we went to just in the Norwalk region were places like Malta House, the Carver Center, Norwalk Community Health Center, CHC Inc., DeFlorio's Variety Market, Person to Person. We went to the train stations, libraries, the South Norwalk Bridge, Open Door Shelter, preschools, schools, Norwalk Community College, health fairs, and provider offices. And this is not a total list of everything, but these are some of the sites that we partnered with or we did outreach at. We also assisted sites like preschools setting up vaccine clinics at their schools for their parents and families. And then did a lot of outreach efforts at the Carver Center. We had an information table where parents could come and ask questions about the vaccine, and we would educate them on the importance of it, and answer any questions or concerns they might have. The total community members reached were over 11,000 residents that were reached through our outreach efforts. We also have a vaccine assist line at the health department, and that number is listed on all of our promotional gear that we give out and hand out. And so that line is really for folks to call in who have questions about the vaccine, if they need to help with making an appointment, finding a location or a vaccine. And so through that vaccine assist line, and that was, I assisted, when people would call, so did the CHWs. We assisted 528 people to actually make appointments for them, to get the COVID vaccine. And then early on in the vaccine rollout, the health department, we still are a provider of the vaccine. So we were able to have access to our own records of who we vaccinated. And then, during a downtime, the CHWs took on a project with CTWiz, which is our state immunization registry. And so we were able to review some of our records of people we had vaccinated to see if they were eligible for an additional dose or if they hadn't completed a series. And so we reviewed 1,853 records, and we did 52 referrals, meaning calling folks and making maybe additional appointments for them to get a complete series or a booster. And then the grant period, this data is just from January 2022 to October of 2023. And then a little bit about tests. I'm sorry, did somebody say something? Test kit distribution. And so the health department in total had, we've bought and or received home test kits. And so we've been able to distribute over 19,000 test kits throughout those grant period. Some of them were assisted by the CHWs, at events they would bring them. Others were delivered to sites like the Malta House or other locations that requested test kits from us. So we were, through test kits that were provided through DPH or grant funds, we were able to distribute a lot in the community. So tracking and use of data. So this is always important when we're looking at health equity to ensure that, the high-risk areas of the community are getting enough resources and that we're ensuring that they have access to the vaccine. So Brian, our epidemiologist, worked with us to create this GIS mapping system where we could track the work that we were doing. Early on, we were doing a lot of door-to-door canvassing where CHWs were going out knocking literally on door-to-doors and bringing COVID information as well as other information, to stay safe. And so we wanted to track to see where we were going in the community, ensuring that the places with the lowest vaccination coverage were getting a lot of our resources, as well as high vulnerability areas. And so this right here is just a screenshot. I do have a video I'm going to try to play on the next slide to kind of show the system. But we were really able to look at the total region that we serve, also looking at the fully vaxxed rates, and then comparing where we needed to target a lot of our work. Let me see if the video will play, and it's a voiceover, so you'll hear me presenting. If you guys could let me know. Give it a second. Can you guys hear it?
No.
No.
I'm going to do the voiceover live then. So what you're looking at is the GIS mapping system. It's going to go ahead and zoom in and out for a minute to show the different regions that we cover. Again, it's Norwalk and the surrounding towns, as well as Danbury and the surrounding towns. The colors on the screen represent the vaccination coverage rates in those areas. So that green is going to be that lowest level vaccination coverage. Just showing it there. And then we're going to go to the key on the right side. And so the key on the right side, we were able to, I'm just going to pause this for a second. We were able to document where we went to do outreach at. So if we were going to churches or businesses, community centers, schools, if we were engaging in provider offices, if we went to health fairs, farmers markets, food pantries, the library, the train station, we were able to capture all that information in this system. We were also able to document, and I'm going to let it go ahead and play so it can show you a little bit. We were also able to document the routes that we did door-to-door canvassing on. So when our CHWs would go door-to-door, sometimes they would just be with our CHWs. Sometimes we partnered with Family and Children's Agency because they had CHWs also. So we would do joint efforts with canvassing. And so we really wanted to capture, you know, areas that maybe FCA had already done or areas that they had done together. And so I think in this video, I was just explaining that part. But if you clicked on any of the icons in here, you would be able to see where the CHW had gone that day, what area of town, what kind of outreach efforts they had done. Now I'm zooming in to show some. So now you can kind of see those green and blue lines. So the blue lines were planned routes that they had planned to do outreach on. Pink lines were Family and Children's Agency had, you know, completed those. You're not going to see any pink lines in the Danbury region because Family and Children's Agency was focused on Norwalk only. The green lines were routes that we completed. And so this was just an example of some outreach efforts that we did at Western Connecticut State University. We partnered with the Danbury Health Department. They had a flu clinic and they invited us to come and do outreach at that event. Just gonna go forward a little bit to the Norwalk area. So then again, this is just an example of outreach at the Florio's Variety Market, where we partnered and we had done outreach outside. We had given out masks and test kits outside at this event as well. They were a great partner and always love to have us. Just moving on. These are just
Can I
yeah,
ask a question?
Mhm.
Every week I get a printout, New York Times, Fairfield County COVID data.
Mhm.
And if you look, the last one, February 3rd that I have, the primary series vaccination rate was 86% for all ages and 95% for 65 and up. But for the bivalent booster rate, all ages were 23% and
Mhm.
65 and up was 56%.
Yeah, so this, and Brian can speak to the data on this, but this was before that new bivalent came out. This was tracking
Okay.
that. So it was when we were able, because the state stopped providing some of the data to us, we couldn't continue to update that system. So that was, I should have mentioned that. So that had the data, and I would have to go back to see the last update of that system. But that was just with, not with the bivalent doses. So
Okay.
it would be
Thank you.
interesting to update. Yeah. Sorry about that. I didn't mention that.
So I have a question. The data tracking the incidence of COVID. I've read a lot that the data is getting more and more inaccurate because basically people are not reporting it. People are going and getting sick and they're not that sick, so they don't get a test. Is that being reflected in the data?
This data that we're looking at is vaccination coverage. And so Brian is probably going to present, and he could probably speak more to what you're asking about, Dr. Reed.
Yeah, so vaccination coverage just equates to vaccine uptake. So it's reflective of areas where there's opportunities to do further outreach, that obviously hasn't, gone at the same level as other regions of comparison, things of that nature. That's the reasoning for it.
Okay.
Thank you, guys. So here's just a couple examples of some material. Again, this was material that was passed out early in 2022. And, some has been updated since, but some examples of outreach efforts. Obviously, our main focus of this program is to promote the COVID-19 vaccine, but we also promoted the importance of other, protective measures like hand washing, mask wearing, staying home when ill, and, taking home tests. And a lot of these materials were translated into Spanish, Haitian Creole, and Portuguese. So the Danbury region, which we oversee, there's a high population that speaks Portuguese. So we worked with the Danbury Health Department to get a lot of our stuff translated to meet the needs of that community as well. Again, just some additional information that, was created locally, but we also used a lot of information that the Department of Public Health at the state level provides to us, as well as information from the CDC. And then these are just some additional things that we created locally.
How are we measuring success of our programs?
So I would say of our CAP program,
Yes.
yeah. So we have our performance management system that we review quarterly. And so within that performance management system, we have certain metrics to measure the work that we're doing here. Outside of that, we do provide a progress report to the state quarterly with, it's like 100 pages I provide to them of all the work that we're doing, measuring the amount of people we've, reached, the amount of people we've assisted to make vaccine appointments, the amount of outreach education and events we've attended, a lot of those things. And again, just moving on to them, these are some other things that we would take out into the community. CTWIS, which again is our immunization registry system. Folks can go on there and look up their own vaccination records. So we would bring these out to help people, be able to access their records on their own. And then moving a little bit to some other work that we do with the program is really supporting providers. Again, early on in the vaccine rollout, local health departments were the primary source of, getting folks vaccinated, but it has moved back to the traditional model where you're going to your provider to get vaccinated. And so throughout the pandemic, we have been still hosting these advisory committee meetings. So me and Pam partner and invite a lot of providers from the Norwalk and Danbury regions to attend these meetings. We have guest speakers from the state health department, as well as vaccine reps and representation from the Norwalk Health Department, as well as the Danbury Health Department, to share and educate providers on, all array of things. And so these are just some examples of our meeting agendas. We hold them twice a year, and they are really well attended, and providers really enjoy the information they get from them. They're able to ask the state health department questions as well as us. So some other work that came out of our CAP program was a partnership with the Autism Society of America. And so their focus is really to increase vaccine education initiative through vaccine education, confidence, accessibility throughout the autism and disability communities. Part of this program is to provide practical tips to improve vaccine confidence by employing strategies to reduce stress when vaccinating neurodiverse patients and opportunities for community impact. They do this by providing training and sharing it with the community and community partners and distributing these accessibility kits, which you can see below in the photos. And so I had joined a Connecticut Immunization Coalition webinar in July, and this was their guest speaker, was the Autism Society. And so they were asking if anybody would like to partner, and I thought this would be a great opportunity for the Norwalk Health Department CAP program to partner. I knew we had a great reach with our providers, so we were going to be able to share this with our providers and share this with the community, as well as use these kits at our vaccine clinics. So we partnered with them, and we were able to receive 500 kits from them to distribute in the community. And so these kits would go to anybody coming into a clinic who might benefit from some of these resources. I'm going to continue to show you guys some of those, what's in those kits. So through our partnership with them, we trained 16 emergency response volunteers at the health department, and we also trained and shared with 17 staff. So anybody who was working our clinic, even if you were not a vaccinator, so somebody like myself who might be helping at registration, received the training and the material. Are you guys there? I just see people froze. Oh no, you guys are there. And so we use these during our fall clinics, our flu and COVID clinics. And then this partnership was presented during our December advisory meeting. 31 providers attended that meeting. 10 offices have requested kits, and our new CHW, Omar, has already delivered 185 kits to provider offices. And so we have additional kits remaining where we can use them during our clinics, or if some offices need more, we're able to bring out more kits. And so some additional things that are provided along with the kits are on the left side, it's just getting the COVID vaccine. This is kind of like a checklist sheet that somebody can use to give to a patient so they can follow along with the process of getting a vaccine. This is helpful for somebody with autism or any kind of neurodiverse disability, because it kind of keeps them understanding where they are in the process, keeps their stress low because they know what's coming next. And then to the right are some communication boards. And so these are for nonverbal, or some people become nonverbal during a medical encounter. And so this is just to kind of help that person get through that appointment. And then this is what's in the kit. So it comes with a little card that kind of talks about all the items in the kits and why they're useful in English and in Spanish. So there's noise canceling headphones. That's to help manage sound and balance. There's a shot blocker, which is this yellow little thing here, rubber patch. And so that's a non-invasive tool that lessens the pain and anxiety of the needle. So you actually put that little prickly thing on the person's arm, and the shot would go in the middle. And you know, they're focusing on that prickly thing, so they don't actually feel the needle then going in, or it lessens the feeling of it. There's a stress ball. This is to help support self-regulation and decrease stress. A fidget spinner to help support self-regulation and to decrease anxiety. Sunglasses to help manage light sensitivity. And stickers are for rewards, because it's always nice to get a reward once you've gotten a vaccine. So just a little bit about our evidence-based approaches. And so, you know, we're following evidence-based models to conduct all of our work, like you've seen, following national organizations like the CDC and the Office for Disease Prevention and Health Promotion. We're also looking at Healthy People 2030 and other infectious disease evidence-based resources. And so this was just a screenshot with a link for some examples of where a lot of evidence-based information that we're able to refer to when we come to really our approach and the work that we're doing. And so, you know, moving forward, and what we've continued to do is really partnering with trusted messengers like healthcare providers, community organizations, and having community health workers to provide information and reassurance about the vaccine. supporting healthcare providers to better enable them to be the main source of this information and the go-to supplier for the vaccine. And so that's really what our effort has been, really pushing to help support those providers. Again, early on, it was local health departments, but it has moved back to the traditional healthcare model. And so we want to make sure that we're support to them. If they have questions or concerns, they're always able to reach out to us. We want to make sure we're always using plain language and health literacy concepts, multiple channels through trusted messengers, in person, in print, online, to increase equity and communication. And then moving away from the mandates and the communication, building trust by providing people with accurate, compassionate, transparent information to allow them to make informed decisions. And so that's really what our community health team and our community health workers are here for. They're out in the community. Sites have asked us just to come out and have an information table because people have been curious about the vaccine or have concerns. And so we're there just to educate and answer any questions that they have. And that's all I have. Sorry if I went a little over. I'll take any questions.
Thank you, Megan. That was really, really great.
Yeah, that was good.
That's a terrific, diverse set of things you guys are doing in the community. I was surprised you're all the way up in Danbury. That's great. And that's the way we're supposed to do, collaborate with other departments, and it's terrific. Great job.
I know everyone was great about asking their questions, as Megan was talking, but does anybody else have any other questions?
No.
No.
Amazing work, Megan and team, and Teresa's on as
Thank
well,
you.
which is a big part of the team too. Thank you both. All right, we're gonna move on to Brian, who's gonna give us some epidemiology updates. Good morning, Brian.
Hey, good morning, everybody. So I'm going to keep it short and sweet. I won't pull up the usual kind of screen presentation because fortunately, generally it's good news. And so just to speak really quickly about the COVID and the respiratory illness situation, and to Dr. Reed's point, just to mention, again, a lot of data is not looking at the disease burden because to that point, there's a lot of gaps because a lot of people are doing at-home testing. And so the optimal thing is, the emergency department visits and hospital admissions. And so with that said, as a reminder, that typical map I pull up with the green, yellow, and orange levels, that's the new COVID hospital admission rate by week, by county. And so fortunately for Fairfield County, we have 3 weeks where we're in the green, and it's actually been continually downtrending. And so we're at 5.9 per 100,000. Keep in mind, to enter the yellow level, that you have to be over 10. So it's actually really good news in terms of the COVID situation relative to Fairfield County, and including the whole state of Connecticut, because all counties are in the green as well, and they've also experienced, generally speaking, 3 weeks of generally downtrending trends. So that's great with the COVID situation. With its decrease, flu is actually out competing COVID at the moment for the state of Connecticut. RSV levels are very low, which is very good to see too. So generally speaking, the way to look at this data is kind of we're halfway there towards baseline levels, but we're not nowhere near where we're at the peaks. Oops, got a little bit tongue twisted there. Yeah, so overall, the respiratory illness situation is very good. Did want to mention as a reminder, we're kind of making our way through the peak activity of norovirus, which actually can kind of go till around May, June. So we have a little bit of a long ways to go with this. But it is actually, acting up right now, but it is mirroring kind of like the previous year as well. So it is not something that's too abnormal. It's actually still a little bit lower in terms of that peak activity. So it's kind of a little bit better. But again, keep in mind, we have till like May or June to kind of deal with this in the Northeast, as well as the West Coast is experiencing that notable uptick. But yeah, I mean, more or less, that's kind of just the quick update. Again, this is just kind of just let you guys know. It's not really meant for like full-on general communications. That is not my domain, so I just wanted to make sure that's clear as well for the public. But yeah, that's really the update for now. Thanks, everybody.
Any questions for Brian? All right. The next item on the agenda is about a new proposed vaccine, HEPLISAV-B. I'm going to pass it on to Darlene to give an overview, and then if Dr. Reed has anything to add, to also provide information. Darlene?
Good morning. So with the recent ACIP recommendations that all adults aged 19 to 59 receive Hep B vaccine series, we'd like to offer patrons the option of receiving the 2-dose Hep B vaccine, HEPLISAV-B. We shared that information, some information about the HEPLISAV-B with you prior to the meeting, so hopefully you had the opportunity to look it over. Currently in our inventory, we only have the 3-dose hepatitis B vaccine, Engerix-B. And according to the literature that we shared, 75% of the adult vaccine recipients didn't complete their 3-dose vaccine series. Vaccine effectiveness can't be assured if the entire 3-dose series isn't completed. And in practice, we found that it can truly be a challenge to get individuals to return for their 3rd dose. One, because the 3-dose schedule is drawn out over a 6-month period of time. Also, number 2, the necessity for us to have a good reminder recall system that's consistently used that will, remind folks to come back for any additional doses. And 3, because many people, they're just anxious about receiving vaccines to begin with. And if you have several months between doses, there's a good chance that they're not going to return for their last dose. The HEPLISAV-B is a 2-dose vaccine series that's administered 1 month apart. This schedule is more conducive to series completion. The 2-dose series confers protection sooner than the 3-dose series. And this is especially important for those that we service who are traveling abroad, who initiate their vaccine series, receiving their vaccines within 30 to 60 days of their intended travel. They need their immunity sooner than later.
Yeah.
You'll note that according to studies, if you got the opportunity to review some of that information, HEPLISAV-B has a high rate of seroprotection within a shorter period of time. And the safety and adverse event data is terribly different between the Engerix and the HEPLISAV-B. So the vaccine is being presented for your consideration and approval so that we can include it amongst the other vaccines that we provide. Does anybody have any questions?
No.
I'd like to add that I think there are some real advantages of this. In the travel clinic, you'll see people who got their 2 vaccines and went to Africa or wherever they were going, and 2 years later they come back and they've not had their 3rd. It's very common for those reasons. Out of sight, out of mind, people don't do it. So the other thing is when I looked over the literature, this actually has a higher rate of protection than the traditional 3-shot series. So that's important information. And I think that if we'll get to it later, but the cost for the 2-shot is significantly less than the 3 because you don't have 3 visits and you don't have to pay for 3 vaccines. So I think this is a winner. The side effect profile is virtually the same as with the traditional, and most vaccines have a typical profile of minor discomfort. And so I think we would move to this as soon as we can because we have to make sure the insurance companies will reimburse what they will because it's produced by the ACIP. I mean, it's been approved. And so that'll bring that process along, if they're all there yet. But this is, I think, an important improvement to our armamentarium of vaccines.
Thanks, David. Thank you, Darlene. Any comments?
No.
So I'd like to ask that you all, if you're amenable to it, to add this to the vaccines that we're offering. Can I ask for a motion?
So moved.
Norman,
Second.
I think seconded. I think Terry got that first. Thank you. All those in favor, say aye.
Aye.
Any opposed? Any abstentions?
Mm.
Okay. It passes. Thank you very much. So we will move on to the next item, which is the vaccine fees. So Carla Rodriguez Alicia. She's going to give a brief overview of the process that we use to, update our vaccine fees, and then if Darlene and David have anything they want to add. Carla, are you able to give a quick update?
Hi, can everyone hear me?
Yes, we can.
Yes.
Excellent. Sorry, we're having some technological issues this morning here. So I apologize for that. But Deanna, if you wouldn't mind just pulling up the spreadsheet that we prepared. This spreadsheet was sent out per our email last week. And I'm just going to discuss a few of the looking at our vaccine costs. So when we look at our vaccine costs, we do compare them to our competitors in the area. And we look at what vaccines are most important out for our residents, right? We want to make them affordable for our community, yet we do want to be able to cover our costs. And what we've seen in some of our vaccines with our prior costs is that we're actually paying more out of pocket than what we're getting reimbursed or what we're getting from our patients. So when we do our cost analysis, our yearly cost analysis, we put into consideration the amount of time that the nurse is in the room with the patient. We put into account as well as the cost. So you'll see in this spreadsheet what our current fees are, our actual costs, meaning what we pay for the nurse's time, all the supplies that go into that actual visit, and then our new fee that we are asking for, requesting to increase. In general, we have about an 8% increase that we're looking at here, but you'll see everything in orange is an increase from our current fee. Everything in pink is a new vaccine, so you'll see that new vaccine that Darlene was speaking to. And everything in black is no increase. You'll see that the majority are, for our flus, our HEPs, our meningitis, definitely our yellow fever as well at the bottom. And that's pretty much what goes into our price increases. We are still billing our insurance carriers, and we are still getting a certain percentage of that cost back. Not all insurance carriers are reimbursing us exactly what we are paying out, but we do like to provide that service for our patients that are traveling or that are in need. Any questions on our vaccine increases or on how we calculate our vaccine costs?
I'd like to make a few comments. We've been doing this for a long time, and I'm glad to hear we're doing it yearly, because I remember Tim one time didn't do it for a few years and then proposed increases, and everyone said, that's quite a jump. And the conclusion was we should do it yearly. And I think that's a good thing, because clearly we caught a number of vaccines where we were underpriced. And so I think that's a good process. I'm a little different on some of these things. I'm not sure why we lowered the price on a couple of vaccines by $5.
Yeah, that's what.
I don't think we need to do that. The extra profit can go for the ones we don't get paid that well for. And the only other observation I would make is that we're still very competitive. If you look at the list of the regional people who are vaccinating, that we are quite reasonable. And you can see there, by the way, the new Hep B vaccine priced at $155, and it's $180 if you get the old vaccine. So that's a real winner. But I would suggest at some point we think about applying a multiplier for the profit, because we're sort of making it up as we go. And maybe we should target 8%, 9%, 10%, whatever we want to do, and apply that to prior ones. It'll get a more uniform result. And again, the extra revenue, as long as it does not prohibit the expenses, which I doubt it would for people getting the vaccines, it provides revenue to support our other activities, which is always helpful. I think what we've done here is fine. I'm not talking about this year. I'm just saying next year to look at it in a more systematic way.
Thanks, David. Does anybody else have any feedback? do you agree with David's assessment? I think the flu ones were the ones that have been proposed as 45. Do you think we should keep those at 50?
Yeah.
What are the board members think?
Obviously, to the public, they're not gonna know what hit them. I think that having a process to do the cost accounting side of that it might be something that we want to look at in the future. It's not easily done over a quick, how do the rates look like? But it's important to be competitive in the marketplace, but you don't want to price yourself out of that market. I don't think we do that here at all. So I think there's a good process you can stand behind. I think that the cost accounting side of this it's really tricky when you have to incorporate no payment options and different payer attributes, et cetera. But I think that it's important to stay up with it. As David said, we didn't at one point in time we had a loose policy that kind of went along as we did it with Tim stuff. But I think that once we put in that final cost accounting methodology, it went very well. I think that's a good way to continue.
I'd like to add one other thing, just overall with the price of vaccines in the clinic, I have people who've come from the Catskill area, Massachusetts. People come from all over the clinic. And I say, gee, what brings you here? He said, oh, I looked it up online. I saved $500 coming to you guys. And that's because some of the high cost vaccines we provide at a much more competitive rate. And we certainly know that with Passport One. Anybody who's been to Passport One, it's much more expensive. It's a different model. We have, covered overhead from the city for our regular job. This is an addition. They have to provide new space and so forth. But it's a true bargain for most people, and they recognize it. And so I think we're doing a good job. We just have to kind of keep our eye on our fees and keep them competitive and keep them as substantial as we can to support our work.
Anything else? Carla, do you have your hand raised? Did you have anything else you wanted to add, or? All right, so where are we? Do we want to vote on the proposed fees as we've presented them, or do you want to make any edits?
Deanna, can I speak for a second?
Yes, please.
I think Carla might be raising her hand to address the fact that I know that it appears that there's a recommendation to reduce the flu fee from 50 to 45, but I think the numbers were placed in the wrong columns. So it's actually, it's been 45. We're proposing to go to $50 for flu.
Oh, okay, darling, thank you.
Well, that makes sense.
Yes.
Much more understandable.
Okay, so do I have a motion to accept the fee schedule as presented with the correction of the flu at 50?
So moved.
Harry moves. Do I have a second?
Yes. Second.
All those in favor, say aye.
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 Any abstentions? Any nays? All right, it passes. Thank you very much, everyone. And thank you, Carla, Darlene, David, Brian and his team too. They also helped with doing research on, what are the competitors, what is everyone else offering. So thank you to everybody. It really was truly a group effort. And of course, the board, you're the ones who set us on this path of really looking into, what are the costs to provide the services. So thank you. All right. It is 8:55, so I'll be quick with my director's report. We are happy to share that we have a new WIC nutritionist who started. We had a vacancy due to a retirement, but we have a new team member who's joined. So really happy about that. And we're working on fulfilling one other WIC position right now. We have just reposted our receptionist position. We had to go out again to post it. So if you know of anybody, it's just been posted publicly. It'll be for a week. So for our bilingual receptionist position. So that's we're recruiting for that. We've also, Darlene and Carla and others have been leading an effort to renovate our exam rooms. So I don't know if you remember, this is a kind of several years in the making. Darlene was finding some old documents that we looked into when the building got renovated several years ago. And then I had asked in the capital budget to have some increased funds in order to support renovating the exam rooms. But then COVID got in the way and we weren't able to get the job done. And so then Carla joined the team, and then she really took the lead on working with Darlene, the two of them together, getting this project done. So I just really want to thank them. So we'd like to invite you to come visit soon to come see the exam rooms, but it's been really great. Some new updates. Darlene, Carla, anything you want to share related to the exam rooms? There's new painting, new furniture.
Oh, wow.
Yeah, they look really nice. They're almost done. So
Well,
maybe we'll wait till.
I had a chance to stop in the other day when I was doing some documents, and they are really nice. We were in 1950 there, and now I think we're in 2024. Nice modern equipment, and I think the patients will appreciate it, and I know I will. The table will go up and down for one.
Oh, wow.
Lots of little things there.
Oh, no.
You all have to stop by and come see them.
Would it be worth doing a little like grand reopening or something like that?
Yeah, I think that's a great idea.
We could do a little thing and, invite maybe the council or somebody to come.
Yeah, I like that idea.
It's always worthwhile promoting yourself to the people who support you with money.
Mhm.
Let them see what they're getting. They'll like that.
We could do that and have our board meeting in person.
Yeah.
Wow, you really have got this promotion thing down. You're good at it.
All right, I'm making note of that, so we'll have to make that happen. So stay tuned. Thanks, Terry. All right, and then the last thing I just wanted to mention is the operating budget. So we're in the process of setting the budget for FY24 to 2025. The mayor has put out his recommended budget with the finance department. There were, I believe it was 18 positions that have been requested on the city side, and due to increased costs, they're recommending that none of those positions are in the operating budget. So just wanted to let you know about that, make sure you're aware of that. This is just, it's a whole long, it's a whole process for the budget. There's still the opportunity to advocate and to, be going to the Board of Estimate and Taxation and explaining, the reasoning behind our requests and why they're needed. And there'll be opportunity, for more, for more discussions on the budget. So I just wanted to let you be aware of that. There are several, increases that we requested that are in the recommended budget. One of those was the additional funding to support some of the WIC benefits. So that is in the recommended budget to help support our WIC program. There's some other increases that we asked for related to some IT improvements, office supplies, that sort of thing. But it's really the staffing that we're looking at and trying to figure out, what that looks like moving forward. We had put in a request for additional money for relocation costs, because as you know, our costs have been going up over the past few years. But that increase that we had asked for isn't in the recommended budget. So we'll be going and talking about that too at the BET. So
How many positions do we have in the request that are being held? I mean, do we have one or two?
We requested that a grant-funded public health nurse be city funded, and then we also requested that a part-time position in the environmental health division become full-time. So we had requested 2 new full-time positions.
Can you provide us with a quick summary of that, like board level summary of what we're asking for, and what our expectations should be from a realistic point of view, so we can have that discussion?
Absolutely. Can I actually have something written out? Would that be okay if I just send that after the meeting? I can give you all the
Sure,
details.
something that's already done, that's fine, that'd be fine.
Yeah, all right, I will send that to everybody after the meeting.
Deanna, do you have dates yet for the hearings?
So the meeting set for the department heads to meet with the BET, I believe it's next week for us, it's March 7th. But then the hearing, the public hearing for the operating budget with the BET, I have it on my calendar as March 20th. At 6:30 in the evening.
And do you need support for the meeting with the department heads?
I don't think so, but I will let you know if I do.
Okay,
Thank you.
you're welcome. We'll try and make it.
All right. And then the last item on the agenda, I believe, is public participation. I don't see anybody who's here. Is that correct, Danielle?
That is correct.
All right. So then it's 9:02. Do I have a motion to adjourn? Unless there's anything else to discuss before we wrap up. Anything else?
No,
All right. Thank you all. Thank you to the board. Thank you to the staff for all being on. We'll adjourn at 9:02.
Good meeting.
Okay, yes,
Take
very.
care.
Mm-hmm.
Thank you, everyone.
Hi, everyone.
Okay,
Take care.
okay.